Welcome to this targeted oncology presentation in precision medicine called Advances in the Treatment Paradigm for ALK-positive non-small cell lung cancer. We know ALK gene rearrangements occur in a small portion of patients with non-small cell lung cancer. Patients with tumors harboring such rearrangements are highly sensitive to ALK inhibitors. Our discussion today will be an overview of the biology of ALK-positive lung cancer, methods for diagnosing ALK-positive non-small cell lung cancer, current FDA-approved ALK inhibitors, mechanisms of resistance to ALK inhibition, and potential strategies to combat resistance. I am Dr. Mark Sosinski, Executive Medical Director of the Advent Health Cancer Institute in Orlando, Florida. Joining me today is my colleague, Dr. Thomas Stinchcomb, medical oncologist and professor of medicine at the Duke Cancer Center in Durham, North Carolina. Welcome, Dr. Stinchcomb.
Thank you for having me.
Let's begin. You don't mind if I call you Tom, do you?
Please do.
Tom, so it was 12 years ago, I believe, where the first report of ALK rearrangements in adenocarcinoma of the lung came out of some Japanese investigators that originally described that. And it really defined a subset. What are your thoughts about that discovery, the importance of that? How many patients have this? And let's start with that discussion.
So I remember when that came out, and then I think it's an excellent example of, in thoracic oncology, of a rapid drug development paradigm, because crizotinib was studied in the ALK-positive patients, and that led to a promising activity and a very rapid approval in 2011. And then it was followed by 2 phase 3 trials, one the second line, one the first line, and very quickly we moved this ALK-targeted therapy, in this case crizotinib, to the preferred first-line therapy. I think it was a huge change in the landscape of how lung cancer was treated, because now we had 2 targeted therapies, and I think it really pushed to the forefront the need for molecular profiling of all patients.
Absolutely, and interestingly, this is clinically a different set of patients. They tend to be younger, and the median age in the ALK studies is always kind of in the mid-50s. There's nearly an equal distribution of men and women, which is not what we see with EGFR mutations. Almost always, or mostly exclusively adenocarcinoma, in never smoking or light smoking patients. So there is a different profile of this population, and so clinicians should be suspicious if they see patients with lung cancer in that fit that profile. Clearly, testing should be important. So how do you test for ALK, or how do you find it?
So what we have used the ALK FISH probe, and I think there's some technical challenges with this test. You have to have 15% of the cells showing the split signal, and I think it takes some practice among your pathologists to get really proficient at this.
It's a difficult technique.
It's a very difficult technique, and I think as clinicians we sometimes underestimate the technical challenges for our pathology colleagues.
One of my good friends, Sonia Dasik, who's the molecular pathologist at UPMC, said her least favorite thing to do was to read the ALK FISH results, because it's not easy. Yeah.
It's not easy, and I think they've tried to do some refinements with the ALK IHC test, which is on the Ventana platform. And I think now we're looking more towards next generation sequencing as a way to sort of identify these patients, next generation sequencing on the tumor, as well as potentially the liquid biopsy, which I think has been a huge advance.
Yeah, I think one of the take-home messages for that sort of thing is that at our place we screen with IHC. Yeah. So I think that now is an FDA-approved technique. Historically, we would do FISH in this setting, because the patient that had a positive IHC, I was going to put her on a clinical trial, actually the Alchemist trial. And the FISH result from the Alchemist central testing came back negative. And so we had discrepant results here. I believed the IHC, so we actually sent off next generation sequencing, and she actually confirmed that she had the ALK thing. The point is that if you're suspicious of ALK, you should go through to do next gen and not necessarily settle for a negative FISH.
I agree, and sometimes we get these FISH results that are 9% positive, and you're always a little bit, especially if they're right in the right patient profile, you really want to be diligent and follow up with additional testing.
You mentioned liquid biopsies. Give me your thoughts on liquid biopsies.
So historically, I've used liquid biopsies in patients who there wasn't insufficient tissue, or maybe they've had part of the molecular profiling done and we want a more comprehensive testing. I think the advantage is that it's very easy in terms of clinical management. The patient's in clinic, you draw the blood, and generally you get the results back in about a week. I think the challenge can be that if these are negative, we're not confident that they are sensitive enough to really act upon. So the negative predictive value has to be important to remember. And so many times people are doing either sequential tumor followed by liquid or liquid followed by tumor to make sure that we never miss a patient. That's the critical thing that we want to do.
I completely agree with you. I think the best thing an oncologist can do for a lung cancer patient is diagnose an oncogenic driver, particularly like ALK. And to that extent, the only, I think the other take-home message is that the only time the blood is helpful is if it's positive. If it's negative, you are, is it truly negative or is it false negative? Is there enough shedding of DNA from the tumor into the circulation to find it or not? So, you know, I think it's critical that in my practice, actually, I do both tissue and blood at the same time, realizing that you will find things in blood that you don't find in tissue, and vice versa. And if you don't want to ever miss an oncogenic driver, I think both compartments should be interrogated, you know, for these oncogenic drivers.
I think you bring up a good point too, because the tumor biopsies have always been considered the gold standard, but there's concerns about sometimes you don't get big enough specimens, so it's a false negative, or maybe the biopsy spot just doesn't express
tumor
the
heterogeneity.
And I think more and more times we're going to have to do these as complementary tests at this point. And so I think you never want to miss one of these.
You mentioned before transitioning to kind of the treatment of patients. Before we do that, it's been my sense clinically that we see most of these ALK patients with stage 4 disease.
That's my impression. And I think, because I know we've touched on the Alchemist trial, we've had trouble identifying patients, and I'm not sure if it's a difference in biology, or maybe these patients are young, never smokers, and maybe there's a delay in the diagnosis. I tend to think it's more of a difference in biology personally, because you look, about 20–30% of them present with brain metastasis.
I was just going to ask you that. Brain seems to be, these patients seem to have a higher rate of brain metastases.
And so I think, we do check early stage patients, you know, just that's debatable, I concede that, but we really have not really found, you know, one of the ALK positives in the early stage patients.
Well, I mentioned my patient that I just recently put on the Alchemist trial that was found, she had N1 positive disease, so she had stage 2 disease, but it was tested internally at our place, and that's by IHC, so it ended up being positive. But again, most of our experience has been with stage 4, and you mentioned the issue of brain mets. This is a population that seems to be predisposed, I think because of the underlying biology, to have brain metastases.